Well, the guidelines, the new guidelines are a comprehensive document. Many aspects of hypertension, from epidemiology to diagnosis and specific treatments, are dealt with. So it is difficult to summarize this in a single message. I would think that the most important message is that there is overwhelming evidence that reducing blood pressure in individuals with a blood pressure elevation is highly beneficial, and that it is important to reach values below 140 mm mercury systolic and 90 mm mercury diastolic. This is not easy, but it is possible, and if this is done, hypertensive subjects are protected. I think it's an interesting difference is on the blood pressure thresholds at which drug treatment should be implemented, and the blood pressure targets to reach with treatment. And compared to the 2007 guidelines, revisitation of the evidence has made the new guidelines a little bit more conservative. Now, it is strongly recommended to immediately use antihypertensive drugs in individuals with grade 2 and 3 hypertension, as well as in individuals with grade 1 hypertension but a high cardiovascular risk. On the other hand, evidence is not so strong in individuals with grade 1 hypertension and low to moderate risk. There are trials, but with limitations. And so, concerning this very important category of hypertensive patients, now guidelines recommend treatment, but with a lower level of evidence, and in particular if there are some aggravating factors, such as, for example, an elevation in ambulatory blood pressure. Concerning target blood pressure values, again, there is a shift towards a slightly more conservative approach. While in 2007, the guidelines recommended to have a so-called flexible target to go below 140 over 90 mm mercury in patients in general, but to go below 130 over 80 mm mercury in individuals at high risk, now targets are unified. That is, in all hypertensive individuals, regardless the level of risk, the goal should be to go below 130 over 90 mm mercury. And in elderly patients, the goal should be to go below 140 and 150 mm mercury, because randomized clinical trials do not provide evidence that it is beneficial to go below 140 mm mercury. Well, there are important similarities, but also some differences. Similarity is the process reaching through which guidelines have been finalized. These individuals in the task force selected according to expertise in hypertension, then assessment of the evidence based on pre-specified criteria, and then a transparent and very detailed review process. In both the American guidelines and the European guidelines, there have been 3 sets of reviews. In the European guidelines from more than 60 reviewers. A major difference is that the European guidelines are a comprehensive document. They address different clinical conditions in which blood pressure can be elevated, 19 different clinical conditions, for example, diagnostic aspects of hypertension, assessment of organ damage, follow-up of the patients, and so forth. The American guidelines, they only address 3 questions, very important questions, but only 3 questions. At which level to start drug treatment, target blood pressure with treatment, and how to go there, that is, which drugs to use. Now, as far as target and threshold blood pressure values for treatment, there is an important similarity between the 2 guidelines, very, very similar. There is also some similarity concerning which drugs to use. The American guidelines are quite different from the previous American guidelines. You may remember that in 2003, the recommendation was to use diuretics as first step drugs. Now they advised to use 4 different classes, that is diuretics, calcium channel blockers, and ACE inhibitors and angiotensin receptor blockers. So the attitude is much more liberal, like the European guidelines. The only difference being that the European guidelines include beta blockers, whereas the American guidelines do not. And for the rest, there is also a very liberal attitude concerning combination treatment. Several combinations are recommended for possible use in hypertension. Well, first of all, let me say that I think that the 2 invasive approaches, renal denervation and baroreceptor stimulation, are quite interesting. They do have a rather strong pathophysiological rationale. But on the other hand, I do not think that they will replace drug treatment. I think drug treatment will continue to remain the backbone of antihypertensive treatment and indeed the most important treatment strategy for hypertension. Concerning the importance of renal denervation, well, I think we have to wait. We are a little bit on a waiting phase nowadays because of the information that Simplicity 3, which has the most adequate control group, failed to meet the primary endpoint. We do not know more than this, but we will know in few days from now, because there will be an official presentation at the American College of Cardiology meeting, and I think simultaneously also publication in a major journal, perhaps the New England Journal of Medicine. From that, we will have a clear idea on what is happening. I do not think that renal denervation will cure all individuals with resistant hypertension or even get into the treatment of hypertension in mild to moderate hypertensive individuals. But nevertheless, I also think that renal denervation has evidence of some effect. Not in all patients, but in a number of patients. We have just sent out for publication the data from the registry, 1,000 patients, and now the data are up to 2,000, but only 1,000 have been fully analyzed so far. And in these 1,000 patients, there was a remarkable reduction not only of office blood pressure, but also of ambulatory blood pressure. And this was proportional to the level of hypertension. The higher was the baseline blood pressure, the greater was the antihypertensive effect of renal denervation. So my conclusion would be that pending the data from Simplicity 3, I believe that in a number of subjects this procedure can indeed reduce blood pressure. It will be the future which will tell us where the balance is.